clinical application teaching session from Professor Mohammadi's teaching archives. In this presentation, we will work through a neonatal neuromuscular case that begins with hypotonia, arthrogryposis, respiratory distress, and poor feeding. At first glance, the differential diagnosis is broad. However, the key lesson is that careful bedside reasoning, especially examining the mother, can rapidly redirect the diagnosis toward congenital myotonic dystrophy type 1 and help avoid an unnecessary or invasive workup. Next slide, please. The case begins in the neonatal intensive care unit. We are dealing with a 34-week male infant, born after a pregnancy complicated by polyhydramnios and reduced fetal movements. These prenatal clues already suggest that the fetus may not have been moving or swallowing normally. After birth, the infant has respiratory distress, a weak cry, poor feeding, and decreased activity, yet he remains alert and visually attentive. This preserved alertness is very important because it makes a primary central encephalopathy less likely and pushes our clinical reasoning toward a peripheral neuromuscular disorder. Next slide, please. On examination, the infant has generalized hypotonia, absent reflexes, facial diplegia, an inverted V-shaped upper lip, weak cry, poor suck, and arthrogryposis involving multiple joints. These findings localize the problem below the cortex, the anterior horn cell, peripheral nerve, neuromuscular junction, or muscle. At this stage, the differential diagnosis includes spinal muscular atrophy, congenital myopathies, congenital muscular dystrophies, neuropathies, metabolic myopathies, and neuromuscular junction disorders. But the most important next step is not simply to order every possible test. It is to look for the clue that best prioritizes the workup. Next slide. The turning point in this case is the mother's examination. She may have subtle facial weakness, difficulty opening jars or turning doorknobs, delayed hand relaxation after gripping, or percussion myotonia. These findings may be mild and previously unrecognized. However, in the setting of a floppy neonate with arthrogryposis and facial diplegia, maternal myotonia is a decisive bedside clue. It makes congenital myotonic dystrophy type 1 the leading diagnosis and immediately changes the diagnostic pathway. Next slide. Now we apply the clinical information as a multiple-choice question. The infant has prenatal reduced movement, polyhydramnios, neonatal respiratory distress, poor feeding, hypotonia, areflexia, facial diplegia, weak cry, poor suck, and arthrogryposis while remaining alert. The mother has mild facial weakness and delayed hand relaxation after grip. The question is, what is the most appropriate next diagnostic step? Several options may appear reasonable in a floppy infant, but the maternal examination provides the key clinical direction. Next slide, please. The correct answer is to test both the mother and the infant for a DMPK CTG-repeat expansion. Congenital myotonic dystrophy type 1 is caused by expansion of a CTG-repeat in the DMPK gene. The congenital form is classically associated with maternal transmission because repeat expansion can increase dramatically from mother to child. Once the diagnosis is suspected clinically, targeted DNA testing is reliable, efficient, and far less invasive than immediate muscle biopsy. The best next step is not the broadest possible test. It is the most informative test at this moment. Next slide, please. This diagnosis fits because the infant's phenotype matches congenital myotonic dystrophy type 1. The clinical pattern includes neonatal hypotonia, respiratory weakness, poor suck, feeding difficulty, weak cry, facial diplegia, and arthrogryposis resulting from reduced fetal movement. The genetic pattern also fits. Myotonic dystrophy type 1 is autosomal dominant, but severe congenital disease is most often recognized after maternal transmission. Anticipation explains why a mildly affected mother may have a severely affected newborn. Next slide. It is important to understand why the other options are less appropriate. Testing for SMN1 deletion is reasonable in a floppy infant, but maternal grip myotonia and facial weakness shift the probability away from spinal muscular atrophy and toward congenital myotonic dystrophy. Brain MRI can be useful when dystroglycanopathy or LAMA2-related congenital muscular dystrophy is suspected, especially if there are brain malformations or characteristic white matter findings. Muscle biopsy may help in unresolved congenital muscular dystrophy, but it is invasive and less efficient than targeted DMPK repeat testing when the maternal examination already points strongly to DM1. Next slide, please. This case also illustrates an important principle from modern neuromuscular practice. Congenital muscular dystrophies and related early-onset neuromuscular disorders are genetically heterogeneous, and molecular diagnosis is now central to care. However, clinical reasoning remains essential. We should not allow broad diagnostic categories to replace careful bedside assessment. In this case, the infant initially belongs to a broad congenital neuromuscular differential, but the mother's myotonia narrows the pathway and makes targeted repeat expansion testing the most appropriate next step. A practical bedside approach starts with localization. If the infant is alert, but profoundly weak and areflexic, a peripheral neuromuscular process becomes likely. Next, examine the infant for facial diplegia, poor suck, weak cry, and contractures. Then examine the mother carefully, looking for facial weakness, difficulty releasing grip, and percussion myotonia. If maternal myotonia is present, DMPK CTG-repeat expansion testing should be prioritized. This algorithm is simple, efficient, and highly teachable. Next slide, please. The main messages are straightforward. First, congenital myotonic dystrophy should be considered when a neonate has hypotonia, arthrogryposis, poor feeding, respiratory weakness, facial diplegia, and preserved alertness. Second, the mother's examination is central to the diagnosis and should not be skipped. Third, when maternal myotonia is present, DMPK CTG-repeat expansion testing is the most appropriate next diagnostic step. In this scenario, looking to the mother may be the fastest path to the correct diagnosis. Next slide, please. Thank you for watching this educational presentation from Professor Mohammadi's Teaching Archives.